Hello, and welcome to Shadow Me Next, a podcast where I take you into and behind the scenes of the medical world to provide you with a deeper understanding of the human side of medicine. I'm Ashley, a physician assistant, medical editor, clinical preceptor, and the creator of Shadow Me Next. It is my pleasure to introduce you to incredible members of the healthcare field and uncover their unique stories, the joys and challenges they face, and what drives them in their careers. It's access you want and stories you need. Whether you're a pre-health student or simply curious about the healthcare field, I invite you to join me as we take a conversational and personal look into the lives and minds of leaders in medicine. I don't want you to miss a single one of these conversations, so make sure that you subscribe to this podcast, which will automatically notify you when new episodes are dropped, and follow us on Instagram and Facebook at Shadow Me Next, where we will review highlights from this conversation and where I'll give you sneak previews of our upcoming guests. Today's guest has one of the most unique backgrounds we've ever featured on the show, and somehow he makes it all feel effortless. Dr. Josh Wageman holds a doctorate in physical therapy, a PhD in biochemistry, and is a Yale-trained physician assistant. He's also a nationally recognized lipid specialist, teaching clinicians across the country how to approach cardiovascular prevention with clarity, evidence, and a little creativity. What makes Josh stand out isn't just the alphabet soup behind his name. It's the way he connects with people. Whether he's mentoring students, caring for patients, or speaking at medical programs, he uses analogies, humor, and illustrative storytelling to make even the most complex topics, like lipoproteins and atherosclerosis, easy to understand and even enjoyable. In this conversation, we talk about his book, The Home Security System and the Lipid Neighborhood, which reframes cholesterol and cardiovascular risk into a language we can all understand. We dive into how he teaches both patients and clinicians to embrace prevention, what's missing from traditional medical education, and how meaningful care often starts with time, attention, and compassion. Please keep in mind that the content of this podcast is intended for informational and entertainment purposes only and should not be considered as professional medical advice. The views and opinions expressed in this podcast are those of the host and guests and do not necessarily reflect the official policy or position of any other agency, organization, employer, or company. This is Shadow Me Next with Dr. Josh Wageman. Hey, Josh, thank you so much for joining us today on Shadow Me Next. I cannot wait to talk to you about, number one, your road in your career to where you're at right now, but also this incredible resource in this book that you have authored. Thank you for joining us. Thanks for jumping in.
Hey, thank you so much for having me. I love doing this, and it's always a pleasure.
Thanks, Josh. So you have your PhD in biochemistry. You're a doctor of physical therapy, and you're a PA. You graduated from Yale. Oh my gosh. Can you take us on this educational journey? Tell us a little bit about how you ended up.
Yeah. It's, if anybody has even a remotely similar background, I'd like to meet that person. But basically all that comically viscous alphabet soup of letters behind my name, it really just means that I'm very limited on useful life skills, except going to school and taking tests. But so I have all these letters like, oh, what does that mean? But really it's been a privilege just to have all these opportunities. But what I always say is the magic is in the person, not the credential. But I'll explain a little bit of how this happened. So my first doctorate was actually in physical therapy. And so I'm a physical therapist, and I keep a treatment table at church so that somebody walks in with a Trendelenburg gait, I can help them with their trochanteric bursitis or whatever. So I do pro bono stuff there. But that was my first doctorate. It was actually, I got really, really sick when I was in PT school, and that catalyzed my love for endocrinology and biochemistry. And so even though I graduated PT school and worked as a physical therapist, there was never a sense of finality that I was done there, just because I got really, really, really super sick and nobody could really figure it out. And so I was like, well, I'm going to try and figure this stuff out. And I was like, man, this stuff's really, really cool. So anyway, so that helped foster the person I became along the way. So I was like, well, I'm kind of old, so I don't want to go all the way back to med school. So I figured I'd go to PA school. And that was a super fun time, and went through the Yale School of Medicine for PA school. Enjoyed PA school a ton. That was a blast. And then couldn't help myself, and ended up working on my PhD along the way, as far as cholesterol disturbances and Alzheimer's disease. But really, a lot of this happened too because I'm a lipid specialist. So I'm best known as a lipid specialist. I teach lipid physiology and cholesterol homeostasis across the country. I'm adjunct faculty at various medical programs. I'm also a medical science liaison, and I have to remember to say that nothing I'm saying here today reflects the opinions or medical strategies of Amgen, just so that we can have our unadulterated fun. But anyway, I'm best known nowadays as teaching lipids and for, writing books about lipids. And so, but really the way that I became a lipid specialist, I wish it was some really great, humanitarian reason where I had some Uncle Steve or something, and he had premature cardiovascular disease, and I wanted to devote my life's work to helping people avoid the same fate. But actually, it was because I had a patient cancel one day, and I was sitting there and I was reading some stuff. I read voraciously everything, from Brave New World to the Journal of Clinical Lipidology. And so I was like, oh, okay, well, basics of lipoproteins, which is kind of what the article title was, something obnoxiously condescending like that. And I was like, how hard can this be? I can just throw down a pentose phosphate pathway. If you're lucky, I might throw in a Cahill cycle. I thought, okay, I'm good at this stuff. And so I read this article that was supposed to be a rudimentary review of this topic, and I barely understood any of it, and it made me mad. So anyway, I devoted myself to learning all this stuff, and took the lipid boards and things. And so anyway, so that's how that happened. But along the way, I've hopefully gleaned some things that can help people not have heart attacks, strokes, and dementia, which is my whole goal for what I do on a day-to-day basis. And my whole goal in writing this book that I'm sure we're going to talk about, the home security system in the lipid neighborhood.
That's incredible. I think it is so funny that it was a challenge to you. Hey, I want to understand this better. Why am I not understanding this? I think I get it. And for you to feel that way with all of your education and all of your background knowledge, then to take a step back and realize the people that this is actually affecting, how little they probably understand and realize and know about lipids, how they affect you, what organs they affect, the things that they do on those organs, things like that.
Yeah.
That's probably where you got the idea for the book. Yeah.
Yeah. And, whenever you tackle any sort of subject, you want to make sure that you understand it. And I think one of the ways that you show that you can understand something is if you can explain it to somebody who may not be as familiar with the topic. And I read lots of things, and some of our favorite teachers, I think along the way, probably painted things using metaphors and using word pictures rather than just dealing with esoteric biochemical pathways. And hey, I love me some esoteric biochemical pathways, right? But most people are normal and they don't prefer those things. They like to deal in things that are more relatable to them. And so that's where I was like, I want to come up with a relatable framework for not having heart attacks, strokes, and dementia. And so basically what I came up with is I would start saying this to my patients too. I said, hey, you and I have the common goal of you not having heart attacks and strokes, and then down the line dementia. Yes, that is true. So for you, I want you to have a great home security system, and I want you to live in a safe lipid neighborhood. So your home security system has 4 basic pillars: normal blood sugars, normal blood pressures, keep inflammation low, and don't smoke or do drugs. Those are bad. But then the lipid neighborhood, that's your cholesterol panel, because every ApoB containing lipoprotein, the vast majority of those being LDL particles, are potential criminals that can infiltrate your arterial abode. And the LP(a) particles, if you pick the wrong parents with that genetic risk factor, those are the felons, because per particle, they're about 6.5 times as likely to cause mischief in your arterial wall than your run-of-the-mill LDL particle. Okay, so let's look at these things. We have many ways of measuring your parameters of blood glucose metabolism. And I would say that extends beyond just blood sugar to insulin. Control your insulin, control your life is one of my mantras, okay? So nobody ever said, boy, New Year's resolution 2025, I'm going to be more insulin resistant. No, and nobody ever said, you know what, today's the day I start smoking. This is a good health choice. No. So there's the axioms: normal blood sugar, normal blood pressure, keep inflammation low, and don't smoke or do drugs. But then our lipid panel requires some context, and that requires a little more understanding. because it can kind of look like you're living in a rough lipid neighborhood on paper, but people don't live on paper. So one of my catchphrases is got plaque, get a CAC. What's a CAC? Coronary artery calcium score. It's the colonoscopy of the heart without the nasty pregame show. Because anybody who's ever done a bowel prep knows that will, temporarily ruin your social life and probably destroy your bathroom also. And so, but with the CAC, you lay down, it's a low-dose CT scan, about the same amount of radiation as a mammogram, virtually nothing. And it shows you if you have calcified plaque in your coronaries or if you don't. And that's actually a late finding in the atherosclerotic disease process. It shows you, have you been broken into? And if you have been broken into, do you want to keep living in the same rough lipid neighborhood that got you broken into? Or do you want to consider moving to a safe, gated community with fewer lipid criminals? Seems reasonable. Put another way, if you have any plaque in your coronaries, do you want that plaque stable or unstable? And we know from various studies like ICONIC that most myocardial infarctions don't occur in a vessel with significant stenosis. You're fine till you're not. It's a vulnerable plaque, it ruptures, and then you're 100% occluded. No good. And so, but are there ways to confer plaque stability? Are there ways to even further regress that plaque and further stabilize it? Yes. And so we should probably want to do those and get ahead of the game. And one of my goals is to shift the paradigm for cardiovascular disease from reactionary to preventive. And I think we can do that with just a little bit more understanding of the various tools in our toolbox and the various diagnostic, both biomarkers from a blood-based standpoint and imaging to help inform our decision-making process.
There's two directions that I want to take from this. And both of them kind of, I would love to hear your experience and just speaking with patients about these sorts of things, because I think with both, and tell me if I'm wrong, we really are going to have to partner with our patients when it comes to making changes in this. So I'll tell you what the two are. The first one is illustrative patient education. And the person that I spoke with right before you, Dr. Zarek, he's an internal medicine attending. He brings a whiteboard into the room with his residents, with the patients, with everybody. And he literally does many TED Talks on the whiteboard with a marker. You are illustrative in the sense that you use your words to tell these stories to patients that better illustrates, and clinicians at this point, because you're teaching clinicians how to process this too, to better illustrate this whole process that you just described. So number one, illustrative patient education. We'll get to that. Number two is preventive medicine. And this is obviously something you feel very passionate about. First being the illustrative patient education. Tell me about this. Does this work?
Oh, yeah. It takes time though, right? And that's one of the many flaws of our medical system is people are wheeled in and out in 5 to 10 minute visits. How are you supposed to accomplish anything in that amount of time? And especially when people have questions and they want to talk about other stuff. And I mean, you want to talk about your lives, you want to talk about, hey, how's your kids doing? Oh yeah, no, my kid hit a grand slam last night. And having that human element is huge. So you have to have some time. And you also have to meet people where they're at, because even though, you and I might understand, PI3 kinase AKT signaling when it comes to, the insulin pathway, these people are just like, you're saying words, but I don't understand them and I hate you and I'm going to walk out, so you don't want that. And so you meet people where they're at. And that's why I was like, I need to come up with a way that people can actually understand what we're doing here, because a good reason for a patient is not, I'm a doctor, or I'm a PA, or whatever your title is, and you're just bludgeoning them over the head with your rationales and they don't understand them, because it's their life. You want to help them with their life, but together you are leading them kind of to that conclusion that, because you have, some experience and some clinical acumen, hopefully. But together, it's a lot better when you get there together rather than, you're just forcing them and they feel forced, rather than, hey, let's take this journey together. And so that's why I think it's really important to tell stories and to make it in a way that people understand. And I have a lot of, metaphors in my back pocket, and sometimes the first one doesn't work. So it's like, all right, let's try number two, and so.
Right.
to find a way that can really resonate with them. And that's why there's lots of metaphors, and there's pictures in my book. And my daughter, who turns 8 tomorrow, happy birthday to Mia, she can explain to you, how potentially atherogenic particles are cleared via the LDL receptor, and she can tell you what PCSK9 does, and she can tell you about the ApoB, the Apo bear, and that's her favorite part of the book, because there's pictures there. So anyway, so if you can come up with a way that people from various walks of life, with various backgrounds, with varying degrees of expertise, can really vibe with you, that means a lot. And then people are going to buy in to what you think is going to be best for the trajectory of their life when it comes to cardiovascular health as well. And so, because a lot of clinicians, they complain, oh, people don't do this, people are non-compliant. I mean, I had like a couple, but really, if you explain it in a way that makes sense, I think it's logical, and they realize that you care about them. No one cares how much you know till they know how much you care.
I love that. I really, really like that. No one cares how much you know until they know how much you care. And it does take time. That does take time. I mean, you can't just walk in with a sign. I wish you could. A sign, you hold it up, you say, I really care about you.
Trust me. Trust me.
Yeah. No, and I think the same holds true both for that illustrative patient education, but also for preventive medicine too. Okay, tell me about this. When you're talking with a patient about this sort of thing, as somebody who really gets it, right? Somebody who understands what you're saying and is on board. What is something that you explain to them that surprises them? What's the biggest surprise that patients go, what?
Yeah. So I think, there's a lot of misconceptions, and that's why I had to write a book, but really, I think that historically in our didactic programs, even too, people get taught LDL bad, HDL good, everybody take a statin, put them in the drinking water, And so I like to address those misconceptions most of the time. And so the first one, LDL bad. Well, LDL particles are not inherently bad. They're mailmen, right? Most mailmen are not bad dudes. Their job is to deliver the mail. What's the mail? Triglyceride packages, and then they go home to the liver at the end of the day. That's great. But if one of these mailmen, instead of delivering triglyceride packages to the muscle cell or fat cell, delivers plaquages to your arterial wall and runs a truck in your arterial wall, well, that's a bad mailman. And we need to discuss how to address the corrupt workforce, because you cannot have atherosclerosis without one of these mailmen going rogue and running his truck in your arterial wall. And then it's the maladaptive immune response that results in foam cells, fatty streaks, plaque formation, which then can subsequently lead to clinical events. And so we have to establish those things, because people, it's hard to know what to believe as a consumer or even a clinician, because, some people will be like, oh no, cholesterol is amazing. Well, a lack of cholesterol is incompatible with life. It's an important part of our cell membranes. We need them for bile acids. We need them for steroid hormones. 20 to 25% of our total body cholesterol is in the brain. Pretty important up there. So, so all these things, it requires some context. And so, but just to say that this is bad or this is good, no. And so we have to, it's a little more complicated than that. It's not binary. Additionally, something that patients, I think this is very common for patients, is they think that HDL is good. They call it the good cholesterol. They come in and they're like, well, my ratio is good. Like their triglyceride to HDL ratio. Okay. So what I'll say is HDL cholesterol, and HDL particles, they can do a lot of good things. Okay. So HDL particles are kind of like the police force. They can actually arrive at the scene of a crime in the arterial wall. And if there's a cholesterol-laden perpetrator, they can actually efflux that out of the arterial wall, take it back to the liver, and we can be okay. So that's cool. HDL particles can actually increase glucose uptake into skeletal muscle. Well, that's a really charitable community activity. So they can do all these things. And there's a bunch of other things they can do as well. But just a static measure of HDL cholesterol on your blood panel gives you no idea of its functionality. You don't know if this is a good cop or maybe not so good. A lot of times people with really high HDL cholesterol, they will have dysfunctional HDL particles and they will have advanced cardiovascular disease. And so I had a patient who, she came into me and she's like, oh yeah, I'm fine. Don't worry about my cholesterol. I mean, my good cholesterol is so high, and she wasn't, insulin resistant, so her triglycerides were okay. And her HDL cholesterol was like 108 or something. And she's telling me about her family history though. And her family history is telling me a far different story. and her, brothers are all having MIs and pretty early age, and people are having strokes. And I'm like, yeah, let's get that CAC, that coronary artery calcium score. And her 10-year risk calculator was quite low too, which, I'll tell you how I feel about those. And she had a coronary artery calcium score of over 1,000. Okay, so she had advanced disease and we had to intervene appropriately there. So anyway, so basically just relying on your HDL cholesterol, to tell you anything about its functionality is irresponsible. Now, and so anyway, so that's the HDL story. And that was a long-winded answer to that because I think it's interesting. But really just relying on that to tell you what to do or not do, or if you're invincible or not, no, and obviously statins, do some good things. But they're not a panacea, so being aware of our other tools in the toolbox when it comes to lipid lowering therapy, when you've identified atherosclerosis and you would prefer that to never result in a clinical event, and you're wanting to stabilize that plaque, potentially regress that plaque, get people living in a safer lipid neighborhood, there are ways to do that beyond just worshiping at the altar of high intensity statins. I'm a big combophilic fan. If we can understand the combination of therapies that we can use if we need to in order to get somebody living in a safer lipid neighborhood, it makes sense from not only a biochemical standpoint, but in a way that cannot jeopardize their home security system and their quality of life in the process. Trying to simplify some of these really, really complicated topics is great so that people can actually take ownership of their own health and also help clinicians help their people do that as well.
It's great though, because you're right. If largely, if somebody does not understand why you're asking them to do something and make a huge life change, the likelihood of them actually doing it is probably pretty low. I mean, it's like, why would they want to partner with you? It's like, what did you say earlier? I'm a doctor, I'm a PA. Like, that's not a good reason for a patient just to believe what you're saying,
No.
So no, I think that's so good. Josh, I am so interested to hear what you're going to say to this. Because you went to Yale PA school. I went to the University of Florida PA school. I think we both had a stellar education when it came to our medical education, our PA school education. And you lecture to a bunch of medical schools as well and NP schools and things like that. Yep. Tell me, in your opinion, what is missing right now from the way that things are taught in these clinical programs, whether it's MD, DO, PA, NP, maybe PT, things like that? What are we missing something in our education right now? Because you have such I should have prefaced it by saying you have such a great grasp on this very complicated concept. What are we missing here when we educate our soon-to-be clinicians?
Yeah. So there's so much to know, and I agree. I mean, my program was fantastic at Yale. I loved it, but there's just too much to know because the way board exams are wired. It's like, oh, I have to remember what von Gierke disease is, and so there's all these things that you just have to memorize for your board exams, and board exams are just a whole bunch of information, and they're not really geared towards being preventive. And so if we just incorporated more preventive medicine into our didactic programs, yeah, there are times when you have to say, okay, this is your answer for the board exam. High intensity statin is always the answer for the board exam. But from a practical standpoint, let's talk about how to actually do this a little bit more intelligently, and using things like the coronary artery calcium score. And that has gained a little more prominence, and it is part of our guidelines. But my issue with guidelines is guidelines are not the be all end all either. The 10-year risk calculators, they miss a lot of people. They underestimate some, they overestimate others. And so, for instance, my buddy, he had lipoprotein a, the felon of the lipid neighborhood, as his one risk factor. His 10-year risk calculator was 2.3%. And, he told me about his family history. I'm like, I don't like that. And get your LPL-A, get your CAC tested. His LPL-A was 128 milligrams per deciliter, which is quite high. And then his CAC was 2,814. So any score above 0 means you have been broken into. Any score 300 and above, you have equivalent risk of having a heart attack as people who have had prior events. 2,814 is absolutely stratospheric. He had so much disease that he had to have a 5-vessel cabbage, and he had that 1 year ago. And 2.3%. He was given the attaboy, you're fine, keep doing what you're doing. And he was not insulin resistant at all. no blood pressure elevations. His HSCRP, non-specific measure of systemic inflammation, was 0.4, so not elevated. And he had decided to not do drugs or smoke. And so this was a guy, super fit guy. I run with him. I lift with him. He's actually going to be doing a half Ironman here in a couple months. He's stronger than he was even before the surgery already. But this is a guy who, he might not even be here if we hadn't just gotten 2 additional tests rather than just relying on 10-year risk calculators and our, basic cholesterol metrics. So I think that we can do a lot better job across the board. And it starts with not just our didactic programs, but just education across the board. And I want to equip both patients and clinicians with this information in a way that they can understand so that we can get ahead of the game when it comes to cardiovascular disease and atherosclerosis.
So this book, Josh, your book that you've written, The Home Security System in the Lipid Neighborhood, Uncomplicating Cholesterol and Cardiovascular Disease. And you have just given us fantastic examples of the goodness that is in this book. And you mentioned it's for patients and clinicians alike. Is that true? Could just about anybody hop on Amazon right now and grab your book, open it up and say, you know what, I want to learn more about this for X reason?
Yeah. And I've gotten good feedback from both clinicians and patients alike as far as it being helpful in that regard. And there are certain sections that are more for clinicians. But I tell you, it's like, you remember those choose your own adventure books where it's like, okay, I have the option of, taking this route, or I have this option of going down here. And it's like, oh, that wasn't the right one. I got dismembered by a hippo. I'm like, hey, this is like a choose your own adventure book. You can just go on to the next part. But really, even if you just read the first few pages of it, you get these core concepts of the home security system, lipid neighborhood, and got plaque, get a CAC. Oh, what's LP(a), the felon of the lipid neighborhood, So I, even if you, just had a, cursory glance or two, then I think you would be able to benefit from it. And, my goal is for people to laugh a little, learn a little, and then come away with a relatable framework for not having heart attack, strokes, and dementia at the end of the day.
Which is just such a amazing goal. Thank you so much for writing this book and for making it available to everybody, which is really, really neat. A medical text that we can all read and all benefit from is huge. Josh, before I ask you our last question, I do want to talk about a segment on the show called Quality Questions. This is where we discuss interview questions that you have either asked or that you've been asked that have been really meaningful or memorable in one way or the other. Do you have one of these quality questions?
Before we hear what Josh's quality question is, keep in mind that there's more interview prep, such as mock interviews and personal statement review, over on shadowmenext.com. There you'll find amazing resources to help you as you prepare to answer your own quality questions.
Yeah, what I like to ask people is for them to tell me about a time where they entered into a situation and they had a certain expectation of what was going to occur, and the reality ended up being far different than their expectation, and how they navigated that situation. Because life is full of curveballs, and it's how you're able to adapt to those unforeseen circumstances that often catalyzes what you're really supposed to do when you grow up. And it kind of helps you forge your identity too in what you're becoming.
That's a really, really great one, because I think it gives a lot of students or clinicians the opportunity to talk about sometimes the really tough things. I think we all have those experiences that we would like to bring into a conversation during an interview, but we don't want to sound like a negative Nancy or just like a Debbie Downer. I don't know what the male versions of negative Nancys and Debbie Downers are.
Ooh, yeah. I'll have to come up with something clever.
Yeah. Negative Nathans, I guess. But I think it's a great opportunity for a student or clinician to, address this and showcase how resilient they were. Really. I think it's a great question. Josh, it's been so much fun chatting with you. I already feel like I have a better understanding of so many concepts that HDL is good. Let's talk about this a little bit more. So thank you so much for breaking that down for us. Tell me about, for our final question, tell me about a moment at any point in your incredible career that you are just proud of.
Life is a series of little moments. And if you wait around for the big things like, oh, I got this degree, or I graduated here, or took my board exam, if you're just waiting around for the big moments, you're going to be perpetually disappointed. And so it isn't just one moment that means so much to me. It's just the individual times when somebody truly told you that what you did for them made an impact on their life. And a lot of it is the pictures people give me, the cards that my patients will give me through the years. Those mean a lot to me. And the one that I specifically remember, and all of them kind of blend together in my mind, but there was a gal who had been blown off for so many years, and she actually had pituitary Cushing's, and she had been dismissed by a bunch of providers. And Cushing's can be a little tricky sometimes as far as that workup. And so and then there were still people that were dismissive, and I ended up finding the right guy to do the transsphenoidal hypophysectomy for her, and it changed her life, and she's doing amazing and really got her life back. And so that's really, really special when you're able to invest in somebody. One of my favorite quotes is, when God gives a gift, he wraps it in a person. And if you are able to have that role and just be somebody who cared, that's such a privilege and a blessing to have those opportunities. A lot of times it's, just that you took the time with them to explain some things, and just to show that, that person isn't just a lab number or some sort of diagnostic imaging test. That's a real person, and you really care about them as an individual.
That's so true. I love the fact that you mentioned that it's not just about the big moments. It really isn't. It's culmination of the little moments, which I think is so perfect. Josh, thanks so much for taking the time to spend with us on Shadow Me Next. This has been a fantastic conversation. Where can we find you? Where can we find your book if we have more questions?
Yeah. You generally find me wherever there are lipid discussions going on, but you can find me on LinkedIn, and you can find me on X, formerly known as Twitter. And it's just, my name, Josh Wageman. It looks like Wageman, but it's Wageman. And then for my book, if you just go to Amazon and you type in the home security system in the lipid neighborhood, it'll pop up there. And one of my goals too is to have it very affordable. I just want it to be a resource for people.
Josh, thank you. Thank you for everything you've done. Thank you for what you will continue to do. And thanks for joining us here on Shadow Me Next. I appreciate it.
Thank you so much.
Thank you so very much for listening to this episode of Shadow Me Next. If you liked this episode, or if you think it could be useful for a friend, please subscribe and invite them to join us next Monday. As always, if you have any questions, let me know on Facebook or Instagram. Access you want, stories you need. You're always invited to Shadow Me Next.